Welcome to Falcon Physician Reviews. In this section, we'll review the pathology of the anterior and posterior pituitary. First, a brief review of normal physiology. The anterior pituitary, you'll recall, secretes TSH, prolactin, ACTH, the gonadotropins GH and FSH, FSH and LH, as well as growth hormone. The anterior pituitary hormones are stimulated by hypothalamic releasing factors, with the exception of prolactin, which is tonically inhibited by dopamine secretion from the hypothalamus. And that's an important point for boards, which we'll discuss later. The posterior pituitary we will come to in a later section, but briefly, that the posterior pituitary secretes antidiuretic hormone and oxytocin. Hyperpituitarism can occur by one of three mechanisms: either a pituitary adenoma, a pituitary hyperplasia, or a pituitary carcinoma. By far, the most common cause of hyperpituitarism is a pituitary adenoma. Small adenomas less than 1 centimeter in diameter are termed microadenomas. Large pituitary adenomas greater than 1 centimeter in diameter are termed macroadenomas. And this has actual clinical significance. Many microadenomas can simply be fouled without surgical intervention. They may potentially be treated medically, whereas the vast majority of macroadenomas will continue to enlarge and cause so-called neighborhood symptoms of bitemporal hemianopsia and such, and really need surgical intervention. So 1 centimeter is the cutoff distinction between a microadenoma and a macroadenoma. Pituitary hyperplasia and pituitary carcinoma, that's just to point out that there are other potential mechanisms of hyperpituitarism, but they are phenomenally rare. Pituitary adenomas are of many types. Lactotrophs, which secrete prolactin, can cause a prolactinoma. A prolactinoma is actually the most common type of pituitary tumor. Growth hormone secreting adenoma causing acromegaly or gigantism. You can have actually a mixed growth hormone prolactin adenoma, an ACTH secreting adenoma, which can cause a Cushing syndrome or Cushing's disease in this case. You can have a gonadotrophic cell adenoma hypersecreting LH or FSH, and you can have a TSH secreting adenoma, which is quite rare. The pathology of pituitary adenomas: they're soft, well-circumscribed lesions within the sella turcica. They can result in so-called neighborhood symptoms. By neighborhood symptoms, I mean symptoms that arise not from the hypersecretion of the anterior pituitary hormone, but really from a mass effect. So as the adenoma enlarges and leaves the sella turcica, it can compress the optic chiasm, for example, and cause visual field deficits. Of course, bitemporal hemianopsia is the most common. Other neighborhood symptoms would be headache, for example. Pituitary apoplexy is when you have a hemorrhage into an adenoma, and that can result in panhypopituitarism, and we may discuss that a bit later. Sheehan syndrome is something seen. This is a necrosis of the anterior pituitary, and this is seen after difficult delivery. So if a woman gives birth and there's a lot of hemorrhage, a lot of blood loss associated with that, because the blood supply to the anterior pituitary is tenuous, and really because the anterior pituitary enlarges so much during pregnancy. In fact, it can almost double in size during pregnancy, and there's not a corresponding increase in vascularity. There can be necrosis of the anterior pituitary, and this is termed Sheehan syndrome. Of note, necrosis of the anterior pituitary can occur in other conditions, for example, post-coronary artery bypass graft surgery and a variety of other surgeries in elderly people, but that is not termed Sheehan syndrome. Sheehan syndrome specifically refers to anterior pituitary necrosis following a difficult delivery. Prolactinoma, as we mentioned, is the most common pituitary tumor. Approximately 30% of pituitary adenomas are prolactinomas. They're more common in women than men. They occur in young adults, aged 20 to 40 years of age on average. And prolactin secretion does correlate with the size of the adenoma. So larger prolactinomas will secrete more prolactin than smaller ones. In terms of clinical features of prolactinoma, visual field deficits can occur just as with any pituitary adenoma. The ones more specific to prolactinoma include amenorrhea, galactorrhea, loss of libido, and infertility. So prolactin, in addition to its normal physiologic functions, for example in women of breast development and milk letdown reflex for nursing infants, actually inhibits GnRH secretion from the hypothalamus. And GnRH secretion, you will recall, stimulates gonadotropin release from the anterior pituitary. So because of GnRH secretion inhibition by prolactin, women can get amenorrhea and loss of libido. They can also have infertility. The galactorrhea, that is the spontaneous discharge of milk or colostrum from the nipple, and that occurs in response to excess levels of prolactin. One thing to mention here is that prolactinomas can occur in men as well. They are more common in women. And hyperprolactinemia in men is a little more challenging to diagnose. For example, women have an early warning sign. Young women will have amenorrhea or dysmenorrhea and will present to the clinician because they're not having regular periods, and that's a warning sign. Men don't have that warning sign, and men may simply present with fatigue and decreased libido, which can be misdiagnosed as depression or any one of a number of different disorders. So you have to have a high index of suspicion for hyperprolactinemia in men as well. Causes of hyperprolactinemia, in addition to prolactinoma, include hypothalamic lesions that may interfere with dopamine secretion from the hypothalamus, or medications that interfere with hypothalamic dopamine secretion. So for boards, a patient with schizophrenia taking an antipsychotic, for example, you recall that antipsychotics are anti-dopaminergic medications. So if you disinhibit the anterior pituitary secretion of prolactin, you'll get hyperprolactinemia. Other things that cause hyperprolactinemia include excessive nipple stimulation. So women having excessive sexual intercourse, or female joggers who are not wearing a sports bra who have excessive stimulation of the nipple can actually get hyperprolactinemia. In terms of treatment of hyperprolactinemia, the dopamine receptor agonists, such as bromocriptine, will decrease the secretion of prolactin from the anterior pituitary. Growth hormone adenomas can cause either gigantism or acromegaly. These are the second most common type of functioning pituitary adenomas. They stain acidophilic. Because growth hormone, because the metabolic actions of growth hormone are mediated primarily by insulin-like growth factor 1, IGF-1 levels are increased with growth hormone adenomas. The clinical features, if it occurs in a young patient or a teenage patient whose epiphyseal plates have not closed, the patient may get gigantism. If it occurs in an adult after epiphyseal plate closure, the patient may get acromegaly. Acromegaly is further characterized by enlargement of the jaw, broadening of the lower face, coarse facial features. The hands and feet may become enlarged and continue to grow throughout adulthood. And visceral organ enlargement can also characterize acromegaly. How to make the diagnosis? So one, you have to have a high index of suspicion for this disorder. Two, elevated levels of IGF-1 are the typical way the diagnosis is made. Growth hormone levels, growth hormone has a very short half-life, and its levels increase and decrease throughout the day, so it's quite variable. So measuring growth hormone levels, while that may seem to be the most intuitive way to diagnose growth hormone secreting adenomas, is actually not a good way to make the diagnosis. If IGF-1 levels are increased, a further test to kind of cinch the diagnosis is to try to suppress growth hormone with a glucose challenge. Normally, growth hormone, in you or I, growth hormone levels will decrease in response to a glucose load. In someone with hypersecretion of growth hormone from a growth hormone secreting adenoma, growth hormone levels do not suppress with a glucose challenge. How do you treat growth hormone adenomas? Primarily surgical resection. There are some medications that can be used. Radiation therapy is generally not performed for growth hormone adenomas, and really it's surgical resection. ACTH secreting adenomas are a third type of pituitary adenoma. ACTH secreting adenomas, of course, will result in adrenal hypersecretion of cortisol and hypercortisolism. These tumors stain basophilic, and at this point I'd like to clarify some terminology that med students can occasionally be confused with. Cushing's syndrome refers simply to hypercortisolism of any cause, whether that's iatrogenic in a patient taking steroids for a rheumatologic condition, whether that's an adrenal hypersecreting adrenal tumor, or whether or not that's a pituitary adenoma hypersecreting ACTH. They all have Cushing's syndrome. Cushing's disease specifically refers to hypercortisolism or Cushing's syndrome secondary to a hypersecreting pituitary adenoma. Another type of pituitary adenoma is a gonadotropin secreting tumor, which would secrete either LH or FSH, or more commonly both of these. This represents about 10 to 15% of adenomas. They're frequently found in middle-aged men and women. The clinical features, paradoxically, these patients may have a decreased libido and fatigue. Other pituitary neoplasms include TSH-producing adenomas, which are phenomenally rare. You also get about 20% of pituitary adenomas are non-functional, non-secreting tumors, and we call these null cell adenomas. However, they can result in hypopituitarism or neighborhood effects, for example, bilateral hemianopsia. Another pituitary neoplasm is a craniopharyngioma, and this is a benign tumor derived from the remnants of Rathke's pouch. Recall that Rathke's pouch is derived from the upper roof of the mouth. It's an upgrowth of the roof of the mouth into the anterior pituitary. It's made up of squamous and columnar cells resembling an embryonic tooth bud. These are often cystic in nature and classically described as being filled with crankcase oil. Pituitary carcinoma, as we said before, is quite rare, and I don't think is anything we need to worry about for boards. Hypopituitarism is pituitary hypofunctioning that results from any process that destroys the pituitary. So pituitary tumors, postpartum necrosis, we talked about previously, termed Sheehan syndrome. In hypopituitarism, it can result in deficient secretion of an individual anterior pituitary hormone, or you can get decreased secretion of all anterior pituitary hormones, and that would be termed panhypopituitarism. Decreased secretion of growth hormone can result in dwarfism in children, can also rarely present as hypoglycemia in adults. Impaired gonadotropin secretion can cause retarded sexual maturation in children, can also present with loss of libido, impotence, muscle and facial hair in men, and amenorrhea in women. Decreased TSH secretion can cause a secondary hypothyroidism. So you always have to be on the lookout for secondary hypothyroidism, which is quite rare, but something you don't want to miss. Decreased ACTH can cause secondary adrenal failure, and secondary adrenal failure would lack the hyperpigmentation of the skin because you'd have decreased amounts of ACTH. Now we come to the posterior pituitary. So a review of the posterior pituitary physiology. You'll recall that the posterior pituitary hormones, oxytocin and antidiuretic hormone, ADH, are produced in the hypothalamus, and they're secreted from the posterior pituitary, from the terminal boutons of the neurons that originate in the hypothalamus. Oxytocin induces uterine contraction and release of milk. Vasopressin, or antidiuretic hormone, acts on the renal collecting ducts to retain water. So there's two posterior pituitary syndromes that I'd like to review at this point. One is central diabetes insipidus. Diabetes insipidus is a syndrome characterized by either deficient secretion of antidiuretic hormone or impaired action of antidiuretic hormone on the kidneys. So it can be central in etiology or nephrogenic. Central diabetes insipidus is characterized by deficient antidiuretic hormone secretion. What happens is you get polyuria due to the inability of the kidney to reabsorb water. These patients typically will present with increased serum sodium, hypernatremia, as well as increased osmolality due to free water loss from the kidney. In contrast, nephrogenic diabetes insipidus is caused by impaired ability of antidiuretic hormone to act on the nephron. Classically, for boards, you'll see this in someone taking lithium, which can cause a nephrogenic diabetes insipidus. They'll present similarly with production of large amounts of dilute urine, hypernatremia, and increased serum osmolarity. The way to differentiate between a central and a nephrogenic diabetes insipidus is to give the patient DDAVP, which is synthetic antidiuretic hormone. If a patient has central diabetes insipidus, they will respond quite well to DDAVP, and they will produce a more concentrated, less voluminous urine. If they have a nephrogenic diabetes insipidus, then administering DDAVP will have no or little effect on the production of urine. The history really should tell you what's going on, though. If it's a patient with a history of head trauma or an MRI that shows a hypothalamic or pituitary lesion, then you have to have a high index of suspicion for central diabetes insipidus. If it's a patient with hypercalcemia or taking lithium, then you have to have a high index of suspicion for nephrogenic diabetes insipidus. Another condition is the syndrome of inappropriate ADH secretion, SIADH. Now, classically, this is not actually a posterior pituitary syndrome, but because it involves ADH secretion, we'll talk about it in this section. SIADH is characterized by excessive amounts of antidiuretic hormone secretion, which causes increased reabsorption of water from the distal nephron. This results in hyponatremia. For the purposes of boards, the classic presentation is in a patient with a small cell carcinoma of the lung, but you should realize there's a wide variety of causes. Pain can stimulate ADH secretion, so post-op patients will typically have, will often have SIADH as a cause of their hyponatremia. Respiratory infections or pulmonary processes in general can cause SIADH, and a variety of medications can cause SIADH. But for the purposes of step one, the classic presentation will be a perineoplastic syndrome where ADH is secreted by a small cell carcinoma of the lung. This concludes the section.